then they tend to show contempt for others. Here we come in, like as a nurse, you might be seeing a parent that brings in a child being managed on the ward, and what happens is the parents leave, and they leave maybe an 8-year-old or a 12-year-old to tender to the 2-year-old that is in the ward. At this point, we need to be realistic in the approach. We cannot scream on them or be abusive. We need to call them in, explain to them that the 12-year-old or the 8-year-old cannot give consent to some procedures. They need to be around to actually watch over it, try to counsel them and talk to them. Then there is the societal factor, the socio-cultural beliefs and practices. I think I've already mentioned that the gender inequality in the society, especially in our society here, conflict zones, like maybe the IDP camps and the place where there is war, because there is total decadence and lawlessness, the perpetrators are empowered, they are motivated to continue with the abuse. Then justice approach, delaying justice actually encourages perpetrators. If the patient is not getting justice quickly, like in the case that was presented, it took 2 years, from 2000 to 2005, before justice was served. Within that 2 years, we could have had so many other victims. So many other people would have fallen victims to this perpetrator, because the perpetrator will still be empowered to go around to continue. I will try to use this slide to explain the dynamism of domestic violence. We need to understand that the major aim is power and control. It starts slowly. Maybe what the first thing the person wants to do is first limit, okay, where are you going? The person is quite inquisitive and also always wants to have a little bit of control over the activity of the other. Then over time, the thing builds. It goes from him just wanting to know, to telling the person where to go, to telling the person what to do, to actually even limiting the person from doing anything at all. And they use different tools, like use of coercion and threats, using of intimidation, using of emotional abuse, using of isolation, minimizing and denying and blaming even the victim for whatever has happened. They use children as a bait to always lure their victims in. The male privilege ideology in the society is also being used to make the female believe that they need to submit to the will, and use of economic abuse. The person is dependent on you financially, and so you try to get control. Also, religious factors are also being used to control their victims so that they will accept whatever it is they've done. Health consequences of domestic violence can be affected by the following factors: the frequency, severity, chronicity, and proximity to the violence, age and developmental stage at which the exposure begins, multiple forms of violence being exposed at the same time, presence or absence of loving and supporting adults, presence or absence of a supportive community, victims' individual temperament, opportunities for healing. NCAD showed that 70% of abusive parents were abused as children, and 70% of children abused did not grow up to be abusive parents. It shows that a child being abused does not necessarily mean when the child grows up, the child will be abusive. So we need to actually remove that stigma from the children that are growing up. And if we can reduce the total number of people being abused in our society, we might actually reduce the total number of people that will abuse others later on in life. The health consequences include social vices like aggression, substance abuse, conduct disorders, psychological and developmental problems like depression, anxiety, academic problems, conduct disorders. Then there's the debilitating disabilities that can result from physical injuries and possibly death. Management of domestic violence. We need to understand that it is individualized. Depends on the patient that is presenting to us. A rape victim is managed different from a child that has been battered and injured. And this individualization depends on who is presenting and the facility the patient is presenting to. A multidisciplinary approach is usually involving the physicians, the surgeons, gynecologists, the social workers, the nurses, the pharmacists. Involves every scope of health work. And also it might even involve the legal aid in the hospital in case the patient requests for legal support. Acute treatment of the injuries and long-term management of sequelae with the hope of limiting a repetition of the abuse is actually goal of management. A patient-centered care mode of management is actually what is being encouraged, in which you explore the illness and the disease. You explore what the patient is bringing and also the experience of the patient about what the patient is presenting with. You try to understand the patient as a whole. After understanding the patient as a whole, you reach a common ground with the patient on way forward in the management based on the peculiarity of domestic violence. You must always ensure that you have a rapport, and now you pick a non-judgmental approach in interacting with the patient. You always come together, you create a rapport so that the information flow from you to the patient and from patient to you will be seamless. You impute a little bit of health promotion and health prevention every time you have an interaction with the patient. So the patient can actually serve as an advocate that goes into the community. Like I said initially, the aim is not to save the victim or to punish the perpetrator, is to stop the cycle all around in the society. Then the final part, we need to be realistic, which is what I'm saying, that we need to be very careful how we approach it. We don't shout. We cannot adopt the child because the child is being abused, and we don't want to fight the parents because a child is being abused. We also don't want to create any form of legal framework for the patient without the consent of the patient. Entry into the healthcare represents an opportunity of detection of domestic violence and referral to appropriate community. Hence, proper interaction and detection of red flags of possibility of domestic violence is sacrosanct for all health workers through excellent communication skills. Insist on interviewing the patient privately, because most of the time the perpetrator follows the patient to the hospital, and this might limit the patient's giving up information. Biopsychosocial assessment of all patients that present to the hospital might actually help us detect domestic violence. Pressures of comorbid conditions like alcohol consumption, anxiety, depression can complicate assessment. Intimate partner violence is a very delicate situation, so you ask about it directly. Most patients might not want to give up this information, and if you try to just be systematic about it, the patient might just hide under that and not talk about it anymore. But when you ask directly and you are serious about it, the patient might actually give up the information. You access for suicidal and homicidal ideations in this patient, because depression is one of the major problems that they develop, and they might either kill themselves or kill the perpetrator. The plan and intent should be checked. Incongruent injury, especially in children with history, can actually be a pointer to domestic violence. That way, you can actually explore more with an injury that doesn't correlate with the history that has been presented. You explore family and social history to identify safe havens for the patient, so that when you want to go into conflict resolution, you know the people to invite and how to go about it. Patient's autonomy must always be guaranteed in all situations. You maintain a rapport and adopt non-judgmental approach. You cannot say because the patient is gay and it's not your business. Screening tools that you want to use includes the patient's healthcare questionnaire for anxiety, depression, alcohol, substance abuse. The safe acronym for the perception of the patient's perception to his or her safety in the situation. Single most important thing you want to communicate is no one deserves to be hurt like this. Examination, you have your general examination, specific systemic examination depending on the presentation of the patient. Extensive documentation, body injury should be mapped and photos should be taken if necessary, because of possibility of legal tussles going later on. Possible evidences like clothing and samples should be stored with the consent of the victims for possible investigation and legal procedures. Investigation is individualized, depends on what the patient is presenting, and is inexhaustive. X-ray, ultrasound. A rape kit can be involved if the case is a case of rape, lentiviral screening like in a case of rape, and child neglect, then full blood count as just a general check. Pharmacological interventions include painkillers if the patient is having pain. Like the patient that we presented with, she had a headache, we had to give painkillers, we had to give sedatives. Yeah, she had pointers to depression, but she hadn't got to the point at which we can commence antidepressants. So we're actually open on psychological approach, counseling, and discussing with the patient first to see if we can help improve the mood and improve the total functionality. Antiretroviral prophylaxis can also be used in case of rape. There might be surgical intervention in case of battery. Counseling and family conferencing. This is very, very important, because this is a long bane in conflict resolution. It falls within the bane of family physician and is important in conflict resolution. We insisted, I've been pointing out that the aim is not to save the victim or to punish the perpetrator, is to break the cycle. If you want to break the cycle, you need to involve so many other people so that they can help with the conferencing, and they can help reach out to this person, reach out to the perpetrator, reach out to the victim to find a way of resolving it. Referral for psychological or mental issues, resource involvement, e.g. human rights commission, social workers, and development of an escape plan. This is very crucial, especially between the tension phase and incident phase. Helping the victim identify the characteristics of the tension phase and developing a plan to actually escape from the perpetrator might actually help break the cycle from tension to incidents. A phone line for healthcare or a healthcare provider or someone that can help calm the perpetrator down. An escape route, it might even be a window, a door in the house that the patient can always run through whenever the incident is about to occur. Reaching out to the perpetrator to identify things in him that will make him do that and might limit that cycle. Community resources, these are a list of community resources that patients might be referred to. Of importance, the Miruba Sexual Assault Resource Center. Why physicians do not ask patients about domestic violence? Not enough time during consultation, fear of offending the patient, powerlessness to intervene, even if I ask and the patient tells me, what can I do? No control over patient's behavior, too close for comfort. Family physician is most times the first contact and might be the only contact of this patient. So it's imperative that the family physician has the necessary skills to communicate properly with the patient, coordinate the care of the patient, pick up silent red flags to point out to domestic violence as an advocator at the hospital community and outside in the general community, advocate against domestic violence. As a community leader, reach out for legislation against domestic violence, and as a researcher, gather data into properly understanding domestic violence with the aim of limiting. We need to understand that in the hospital right now, we have a lot of specialists. We work in a tertiary institution, a lot of specialists. And we have a facility that can help in the management of domestic violence, limiting domestic violence in the community. We have different laws, like currently we have the Violence Against Persons Prohibition Law that was passed. The bill was passed at the House of Representatives in 2013, was currently still in the Senate gathering dust, waiting for approval. As it stands right now, Nigeria as a nation does not have any legislation against domestic violence. Only pocket states have legislation like Ekiti, Lagos, Ebonyi, Jigawa, and Cross River. And according to Project Alert, only Lagos uses this legislation judiciously. We have a staunch social-cultural and religious belief supporting domestic violence. Even our legislation currently approves of domestic violence, like the Penal Code Section 55, agrees that a man can beat a woman if they are married, if it is accepted in their society, and if it doesn't lead to any bodily injury. That is the law encourages sanctioning the act of a man that is violating his wife. Even though we pick domestic violence, we currently do not have any form of framework to actually follow up on these patients for psychological evaluation. We need to understand that most of the researches focus so much on physical abuse that we forget about the financial, emotional, psychological abuses. So as a form of recommendation, we recommend that the hospital set up a multidisciplinary team and build comprehensive service to domestic violence victims within the hospital, create a case register for domestic violence victims for comprehensive data collection and possible intervention, written protocols and referrals for effective management, set up a family health care clinic, educational materials on violence for clients and providers as the health workers and the patients attending the hospital, ongoing training and support for multidisciplinary team for effective service provision, reform civil and criminal legal frameworks. We have a lot of important personalities in our midst which can help reach out to the legislative arm to better improve our legislation, even in Kwara State, organize media and advocacy campaigns to raise awareness about existing legislation, strengthen women's civil rights related to divorce, property, child support, and custody. Females are the most vulnerable. In conclusion, domestic violence is a frequent problem which can affect any individual, regardless of age, socioeconomic, or social status. No clear risk profile exists, and the health consequences of those affected by violence are serious. Health workers have contact with this victim of domestic violence more often than appreciated while carrying out our daily activities. It is important that medical personnel is alerted to this problem and trade in its recognition. Thank you very much.
National Domestic Violence Awareness Month. So sweet in October. Okay.
We'll take few comments, just 1 minute or 2 minutes by the.
Thank you very much. Standing on already existing protocol, I want to actually appreciate our presenters. You can agree with me that this is a very broad topic. And it's difficult to actually do justice to a topic like this within the time given to us. By and large, they try to say some important things. I just want to highlight a few things, you know. I want to say that this condition requires multidisciplinary approach. But by and large, the family physicians being the first contact physicians, we always get them first. And it's very important that as family physicians, we have the necessary skill to be able to identify these cases. The patients won't report, they won't tell us. They won't present spontaneously with domestic violence. We are the one to elicit it. So it's important that, you know, family physicians can identify and elicit the history, even when patients are not willing to volunteer the history. And that is why it's very important that the family health clinic that they talked about, that, you know, as health workers, we actually look seriously into that. That formed will actually be a place where cases like this can be referred to and managed by a team of workers that will include the family physicians, behavioral scientists, the nurses, social workers, legal practitioners, law enforcement agents, the clergy people, and then, of course, with every case, a significant, an important, significant person in the life of the victim. They've mentioned anger management, which is very key in breaking the cycle. If we have only the victim to manage, then we have not succeeded in handling the situation. Of course, as family physicians, the family is our unit of care. So the patient is only a gateway to the family. So that place, that kind of clinic that we are talking about will be a very good place to manage the whole family, manage both the perpetrator and the victim. Then I also want to just point out that they were talking about legislation. This also is very important, because if we start from that level, perpetrators will know that they won't always go scot-free, especially when they know that once the history comes out, they will be liable to some form of punishment. And so that will be a deterrent to perpetrators to stop that act. And I also want to include in my comment that the hospital should try as much as possible to also have a protocol of management. We as a department, we're already trying to develop something like that, so that when we have these cases, nobody is in doubt of what's next to do. We know there's a protocol, laid down protocol to handle issues like this. Thank you very much.
Family medicine. We thank family medicine department presented by
Dr. Mrs. Alabi, Dr. Mrs. Alabi, Dr. Friday, and Dr. Dela. So it's a very topic is very important for us for this period, especially the rising cases of domestic violence.
Very good.
Orchestrated by the stay-at-home that was caused by COVID-19. So we are going to take questions. I've sent a message earlier to the chat box. So if you have questions, you can send it to the chat box, or you raise your hand on recognition, and then you go on to unmute yourself after recognition, and you ask the question. Thank you.
Hello, sir. Good morning, sir.
Okay, I can see the hand of 01402.
Yes, I am Abolarin from physiotherapy department.
Please go ahead.
Yes, thank you for the presentation. My question is this: is there any community awareness about this case? Maybe community education.
Okay, thank you so much, Mr. Polari, to address your question. Please mute yourself back. Then I can see Adebi. Please go ahead with your question.
Thank you very much. This is a very important topic that we have discussed, and it is easily misconstrued and easily malaligned. But to really, my own comment is that of the impact and the part of spiritual leaders in the treatment of these patients, or because we like it or not. Well, the scripture was clear about it. Nobody beats himself. Is the children or something? There's something wrong. Apart from a corrective talking with somebody, talking even at somebody is evil because it predisposes to self-harm. So it's so the arborization is so much that both there is maybe physical, spiritual, social, psychological therapy is very key to this. Most of the time, the person that is in an abusive relationship have a telltale sign even before they started, which they just shun off, and until it becomes a problem for them that they could not extricate themselves eventually. Talking about punishment for an abuser, provided we are thinking of reconciliation, it should not be an issue of punishment, but of a corrective activity. Because going back to the same relationship thereafter, after punishment, may be very suicidal subsequently. Those are my own comments. Thank you very much again for the presentation.
Thank you, sir. So do we have any other questions and comments? Any general comments? Okay, so I think we would allow the presenters to respond to the questions and comments raised. So presenters, you have the floor.
Thank you very much, my superior colleagues, sir. Thank you, Mr. Abolarin, for the question, and Mr. Aderiwe. Is there any community awareness for or education? Yes, we have community awareness and education. But do we have one that is domiciled and structured in our society is the question. Within Kwara State, we don't have any domiciled or structured one. In Lagos, there are a lot of non-governmental organizations that are carrying out community awareness, including the Clean Project, the Project Alert, the Legal Aid. They are all carrying out community awareness on domestic violence. We have the Human Rights Commission also that plays an important role in carrying out community awareness about domestic violence. Of recent, we had the World Women's Day, and the Human Rights Commission gave a very elaborate lecture, even promising justice for all domestic violence victims. But it's not still enough because the reach out is not to the grassroots. Yes, maybe how many people actually understand what they are saying. We need to take the community awareness the same way we take the community awareness of maybe HIV/AIDS or tuberculosis to the grassroots. And that is where we feel the hospital community can come in. if every member of the hospital community takes this form of awareness, we have flyers, we have maybe even jamborees and jingles on the TV, continuously talking about domestic violence, the side effects of it, and how it affects our society, we might actually improve the societal health generally and limit the progression of domestic violence within our society. So, okay. Thank you very much. So, in the absence of any further questions or comments, we are going to take some few comments from the DCMA present. I guess Dr. Usman and Dr. Bujue, I guess they'll be on the call. Again, Dr. Bujue, sir, I guess you're asking for the CMAT. So can we take some comments, sir? Go ahead and unmute yourself, sir.
Oh, sorry. Hello? Hello?
We can hear you, sir.
Yes, we can hear you, sir.
Sorry about that. I had some difficulty in muting myself initially. And again, I thought I saw that the acting CMAC is on this platform, but I'll just go ahead. Good morning to the distinguished elders in the community, in the hospital community present. I also greet on behalf of the Chief Medical Director of the hospital, Professor A.D. Yusuf, and the other management staff. I want to greet all the head of departments present, the medical elders, and then all the other members of staff. I want to congratulate the Therapeutic Care Committee for being able to recommence this exercise, the hospital ground round, which is a very important, which the hospital management considers very important. For some time now, we've not been able to hold the ground round for reasons best known to all of us, the COVID-19 pandemic. So we are glad that we've been able to carry in by being able to hold this meeting on Zoom. So I want to commend the effort of the Therapeutic Care Committee and indeed all that have made this possible. I also want to congratulate the head of Department of Family Medicine. And indeed, I want to also congratulate the presenters for the lucid presentation. I also greet the supervisor, Dr. Alabi, and commend her for a very good job. The topic that has been selected for discussion this morning is a very important one. It's apt and relevant to the times we are. More so, it's been reported that even in the period of this COVID-19 pandemic, there appears to be an increase in domestic violence. So we want to commend you for enlightening us on this very important topic. We look forward to the ground round that will come up next month. And we hope that we'll also have another scintillating lecture. Once again, I want to thank you all for your presence. We're encouraged by the level of participation. I think we have to look at, I know that quite a number of members in the hospital, staff, also were willing to join this session, but it appears that the platform, Zoom platform, is not able to admit more than 100 participants at a time. So probably it's something we have to look at and see whether we can expand the number of those that can key in on the platform. Once again, I want to thank you, everyone. God bless.
Thank you, sir. We thank the Deputy CMA for the comments. I want to apologize on behalf of Therapeutic Care UITH that we cannot admit more than 100 now, but we are promising you by next hospital grand round, which is April, we are going to do something that will allow us to make people participate more than this. We really apologize for this. So I want to let you know that the next hospital grand round will be by the last Wednesday of April, and the Department of Hematology, there's the department that is presenting. And we want everybody also to join us as we join today. And we pray that the next one will be better than this. So on behalf of Therapeutic Care Committee, we say thank you and God bless you.
So, Joe, good morning.